Good morning, all. Hope everyone's doing well today. My name is Dr. Aliasgar Taha, and I'm currently an intern at Dr. Sulaiman Al-Habib Hospital. And today I'll be discussing within the next few minutes about chemotherapy-induced cardiotoxicity and how we can tackle this using precision prediction, using genomics, biomarkers, and AI. So it's known that chemotherapy-induced cardiotoxicity is one of the most serious complications of chemotherapy. And let's start off by defining what is cardiotoxicity. The first one would be if you see a drop of more than 10% or more within the left ventricular ejection fraction, falling below 53%, or the second one would be if you see a 15% or more relative reduction in GLS from the baseline. Also, we see around 90 to 20% of the patients that are likely to develop this complication of cardiotoxicity. And the two most notorious agents that are seen are anthracyclines, which are your doxorubicins and epirubicins, and also the second one being HER2 receptor targeted therapy, which is your trastuzumab and pertuzumab. We do have other agents such as tyrosine kinase inhibitors, cyclophosphamide, and immune checkpoint inhibitors, but these two are the most notorious ones. The issue with the current monitoring is that we often tend to detect the dysfunction or the cardiotoxicity later on after the damage has already been done. And at that point, the myocardium has already been damaged irreversibly. So this calls for an urgent need for us to find new prediction tools, basically precision-based tools that help us detect these dysfunctions earlier. So the aim of my study was, first of all, to systematically evaluate the predictive performance in 4 areas. First one being the genomic variants, second is the circulating biomarkers, third one being the AI-enhanced imaging, and then cumulatively including all of these in a fusion model. And the second one being using all these tools to risk stratify the patient for chemotherapy-induced cardiotoxicity. So the records were identified from 4 databases, Medline, Embase, Central, and Web of Science from the year of 2020 to 2025. The designs included were GWAS studies, pharmacogenomic analysis, cohorts on biomarkers, and the trials assessing AI-enhanced imaging. So moving on to the key findings, the first one being genomics. We have found 4 loci that are particularly associated with chemotherapy-induced cardiotoxicity. First one being CBR3, which is carbonyl reductase 3. This one is associated with the drug metabolism of doxorubicin. Then we have ABCC1 and SLC. These two are associated with the drug transporters, influencing the intracellular accumulation of the drugs within the myocardium. And lastly, we have RRG, retinoic acid receptor gamma. This one is strongly associated with the anthracycline-associated cardiomyopathy, and it has an odds ratio of 4.7. And when we use these loci, and often tend to combine these loci, we have a chance of 2-fold increase in the predictive accuracy compared to the clinical risk factors that are currently being used as baseline today. And this suggests the roles of using genetic pre-screening in high-risk patients to identify these loci. Moving on to circulating biomarkers, we have the currently used biomarkers are troponins, as we know, and BNPs. Troponins are specific, but the issue is they often tend to rise often later in the injury, often 4 to 6 weeks later post-therapy. And the other one, BNP and pro-BNP, they tell you about the strain on the heart, but they're not specific enough. So we have microRNAs, 1499 and 146A. These tell you the injury weeks before, even 4 to 6 weeks before, compared to troponins, and has a sensitivity of around 80%. Again, when you combine proteomic and metabolomic agents or panels together, you tend to increase specificity by 25% more. Coming to the AI imaging, we have something as GLS, global longitudinal strain. This basically measures the percentage of myocardial fibers undergoing shortening within the longitudinal fibers from the long axis of the heart, which is from the base of the heart to the apex. And these are present within the subendocardium. And this area is particularly important because this is the area most likely to get affected by chemotherapy agents, compared to left ventricular ejection fraction, which detects the injury around the radial fibers, and is often late. And this has a score of 0.74 compared to LVEF score, which is around 0.55. Basically, it's random prediction. So moving on to the comparative performance, we compared all of these different tools that I just mentioned right now to the baseline and used the relative performing index as one. So we see that Genomics, as I mentioned earlier, has a twofold increase in predictive accuracy. Next in the ladder would be fusion models. And then we have multi-omics, microRNAs, and AI-enhanced imaging. There's the same thing, but in a graph format. You see that all of them have a good outcome. The only two things, the circulating microRNAs and AI-driven enhanced imaging, falls a bit short, but then this is still, again, better than the tools we have currently. So my proposed workflow would be to start off with the baseline clinical risk factors, assessing the patient. So their age, their cumulative dose they would be receiving within their chemotherapy sessions, their comorbidities, and then also their risk factors such as the family history of heart disease and so on. Then you move on to selecting high-risk patients and performing a genetic pre-screening for them to identify the loci that I mentioned earlier. And this is to identify the hidden susceptible patients. So you often, with the clinical risk factors, you identify the baseline risk factor, the baseline prediction, which is moderate enough. But when you add genetics on top, these panels, you tend to identify the patients that you wouldn't have known who are likely to get affected by chemotherapy-induced cardiotoxicity. Then once you start the patient on the chemotherapy, early on you can start the patient on serial monitoring via the microRNAs and troponin as well to increase the sensitivity. And this is to identify the patients who are likely to go into the cardiotoxicity early on, and then you can start off with the intervention early on. So with the cardioprotective agents such as ACE inhibitors, beta blockers, or even if it's necessary for the patient to stop the chemotherapy agent and switch to a different one.
Yeah,
but that's all.
yeah. Thank you so much.